Yes, very good evening, doctors. In this session, yes, very good evening, doctors. Yes, we are going to discuss the FMGE January 2023 recall questions. Okay, right. We go for discussion. See, I have recollected the questions from the student side and I ordered in the way general pharmacology, ANS pharmacology, cardiovascular, renal, like that. Okay, so first we start with the general pharmacology. Very good evening, Dr. T.N. Med Quint, Deepak, Pratibha Sharma, all very good evening. We start. Find out the false statement by using the graph. Look, they given log dose response curve of various drugs. And here in x-axis, they given log dose value, y-axis, they given response value, and they given the curve A drug, B drug, C drug, D drug, based on the question starts. Okay. Drug C is more potent than drug B. Drug B is more efficacious than D. Drug D is least potent. Drug C is the most efficacious drug than E. So the answer is Wasim Ahmed. Fantastic. The answer is option number A. Drug C is more potent than drug B is a false statement. Why? This was we discussed regularly in a classroom session. That is, when you want to answer this type of question, you should recollect the fundamental. For example, look at this. I come back to this question later. Look here. In log dose response curve, the first point is remember the curve is sigmoid in shape, and then in this the height of the curve, that is called maximum response. The maximum response of a graph is called as efficacy. Whereas look here, the dose at which you are getting 50% of the max response, that dose is known as ED50. That is effective dose 50. And the ED50 corresponds to potency of the drug. If we know this point, based on this, you should answer my question. For example, the dose, that is the dose at which I am getting 50% of maximum response, called ED50, that indicate potency. That means even with the less dose, if I get very good response, that drug is more potent. That means lower the ED50 value, the drug is more potent. That's the meaning. So based on that, can you answer Wasim Ahmed and Pratibha? Just the same question. Suppose I'm asking drug A, drug B, drug C. I given log dose value here, response here, by response. Comment on which one is more efficacious, which is most potent. For example, can you say comment on drug C regarding efficacy and potency in comparison with the drug A? When you compare drug C, the height is less, that means low efficacy. And look at this, only at the high dose it produces response, that means low potency. Whereas in this three, the most potent drug is drug A. Whereas drug A and drug B having equal height, that means equal efficacy. So for the question 1, look at this. If you want to answer the question, look here. Here B and C are equally efficacy. Whereas drug A is the most potent. And drug D is the least potent. Like that should know potency. Okay. Good, Wasim. Your answer is very nice. A and B equally potent. And you say A is the most potent. Drug C is the least potent. Very good. Fantastic. Now, next question. Which type of inhibition is shown here? Suppose I put V max is reduced, Km value same. What is the type of curve this curve? They given irreversible Competitive, non-competitive antagonism, uncompetitive. What answer? Come on. For this type of question, when you say Vmax, that's called efficacy. Efficacy. Okay. And KM-sim. For this type of question, yeah, good. All are start using answering. Good. Non-competitive antagonism. Good. For example, I will explain this question with a graph. Look here. Imagine it's a log dose. It's a response. It's a log dose response curve. Here you know the height is called as efficacy. Efficacy. And the dose at which you are getting 50% response. That is known as ED50, called potency. Now the question, what happened to this dose response curve in the presence of competitive antagonism? Look here, in the presence of competitive antagonism, the dose response curve will be parallelly shifted to right. When parallel shifted right, look at the height, same height. That means efficacy is same. Efficacy is same. That means Vmax is same. Whereas the potency get decreases. Potency, they call Km. Km is prolonged. So if they say Vmax same, Km prolonged mean it's called competitive. That means in competitive antagonism, the DRC shifted right, where efficacy same, potency decrease. But in your question, what they say? They say efficacy. Look at the question. In your question, they say efficacy of the drug decreased. KM-sim. That means, look at this graph. For example, what is given in your question? They given dose response curve. My question, what happened to curve in the presence of non-competitive antagonism? In the presence of non-competitive, the curve will be shifted down. That means Vmax is decreased. That is efficacy get decreases. Whereas the curve is not moving anywhere. That means Km is same. So Km same, efficacy decrease means that's called non-competitive. So in non-competitive antagonism, DRC shifted to down, where efficacy decreases, potency remains same. Good. All are answering very nicely. Fantastic. Next. A drug launched in the market is phase of a marketing post marketing surveillance is found to be associated with the side effect. Which of the following parameter will tell you about drug safety? Drug safety. Come on, answer. When I say drug safety, the safety of the drug governed by therapeutic index. So when you say therapeutic index indicates safety, mean therapeutic index formula LD50 by ED50. Okay, so answer will be option number A. Very good. So answer option A. Good. Now just to revise this area, look, normally when you want to produce a new drug, for any drug, for safety purpose, we do two study. One is called efficacy study. One more thing called safety study. Two study. In efficacy, we do log dose response curve, but the height is called efficacy. The dose at which 50% response, that is called ED50. ED50. That's called potency. Whereas for same drug, we also do adverse effect study, or we call lethal study. In this, look at the curve. The height of the curve indicate maximum lethal response, whereas the dose at which I am getting 50% of lethal response is known as LD50. So LD50 means lethal dose 50. The dose at which I am getting 50% of lethal response known as LD50. See, if I get more lethal effects even on less dose mean the drug is dangerous. Whereas larger the LD50, more the safe. So based on ED50 value and LD50 value, we going to create a formula that is called therapeutic index. The therapeutic index indicate drug safety margin. This is what your question. Safety. Drug safety assessed by what? Called therapeutic index. And therapeutic index formula LD50 by ED50. Now, when you say therapeutic index indicates safety, if we say a drug is having narrow therapeutic index, mean what I mean? That means the drug is totally unsafe. For example, I get some drug like digoxin, lithium. These drugs are some of the example for drug having narrow therapeutic index. My question, if a drug having narrow therapeutic index, you should be very careful while using this drug. Come on, what happens? You should do therapeutic drug monitoring. Estimating the drug level in the plasma periodically, called TDM. Now question to all my students, can you please extend your knowledge? Can I come on? We have one drug called warfarin, one of the orally given anticoagulant. My question is, this drug also having narrow therapeutic index. My question is, how will you monitor the safety of warfarin? Are you assessing the warfarin level in the plasma, or we do something else? How will you measure the safety of warfarin? Warfarin safety assessed by calculating INR value. INR means International Normalized Ratio. The formula for INR equal to patient prothrombin time by control PT. Vasomotor, APTT, activated partial thromboplastin. It is for heparin. Okay. Activated partial thromboplastin time is indicated, or it is a tool used for assessing the heparin. Okay. Whereas for warfarin we do INR. INR means International Normalized Ratio. The formula for INR equal to patient prothrombin time by control prothrombin time. Okay, like this. Next question. Which of the following drug causes effects on BP and heart rate as shown in this photograph? Look at the photograph. Here they give BP response and heart rate response. The findings are systolic BP, mean BP, diastolic. See, the systolic BP, from here it get elevated. Diastolic, from here it get elevated. That means a drug increases both systolic blood pressure and diastolic blood pressure. And what about the heart rate? The heart rate from 80 it get dropped, causing reflex bradycardia. So that means you should know which drug causes increasing both systolic and diastolic BP and causing reflex bradycardia. What answer? Options are epinephrine, norepinephrine, isoprene, dopamine. What answer? The right answer for the question, option number B. Why B? For that you should know some fundamental. Very important. This we discussed in our regular classroom, but again I'll teach you. For example, when you want to study effect of some sympathetic drug on BP and heart rate, look at this. Normally, blood pressure formula. The formula for BP equal to cardiac output multiplied by peripheral resistance. Here, cardiac output indicates systolic BP. And peripheral resistance indicate diastolic BP. Okay. So formula. So now I am going to apply the formula. For example, look at the question. You have options are isoprene, norepinephrine, epinephrine, dopamine. Now look at it. If I give noradrenaline, what happened to BP and heart rate? Look at the points. Look here. Noradrenaline usually acts on alpha 1, alpha 2, beta 1. And it has no significant action on beta 2. It acting on alpha 1, alpha 2, beta 1, no significant action on beta 2. So fine. Now, because of acting on beta 1 in the heart, it may increases cardiac output. Because of increasing cardiac output, systolic BP may get increases. Point 1. Second, the drug has no effect on beta 2. That means no chance for vasodilation. But acting on alpha 1 definitely causing vasoconstriction. Based on that, peripheral resistance can get increases. When peripheral resistance increases, BP going to increases. So, noradrenaline causes increase in systole and diastole. Look at the point. Whenever there is an increase in diastole, the body want to compensate. How? Reflexly, it causes stimulation of vagus. The reflex vagal action causes reflex bradycardia. So, the ultimate point, norepinephrine increases systolic BP, diastolic BP, and causing reflex bradycardia. So, in your question, systolic BP, diastolic increases and reflex bradycardia. So, answer will be norepinephrine. In other words, you should also know this point. For example, what happened to heart rate and BP by using isoprenaline? This is also very important point. Remember, isoprenaline usually acting on beta 1, beta 2, beta 3, and it has no significant action on alpha. So, actions are mainly on beta. Now calculate, because of having beta 1 action on the heart, it may increases cardiac output. Thereby, systolic BP increases. Okay. And it is beta 2 action that causing vasodilatation. Thereby, there's a fall in peripheral resistance. Thereby, fall in diastolic BP. So, isoprenaline causes increase in systole and fall in diastole. Whenever there is a fall in diastole, our body want to compensate for that reflexly, sympathetic system get activated. That may cause reflex tachycardia. That means the take message, isoprenaline causes increase in systole, fall in diastole with the reflex tachycardia. The reflex tachycardia due to reflex sympathetic activation. Like that you should go through. Okay. Now look at the. Now can you look at this? The same question we can put this image also. For example, a drug increasing systolic blood pressure, a drug increasing diastolic blood pressure and causing reflexly bradycardia. What could be the answer? Come on. A drug increasing systolic BP and increasing diastole and causing reflex bradycardia. What answer? Answer is norepinephrine. Okay. Whereas, look at this. A drug increasing systolic BP and causing fall in diastolic BP and causing reflexly tachycardia. Tachycardia means the drug will be what? Isoprenaline. Like that question can be framed. Okay. Now look at this question. Next is very important. This is a commonly discussed question. It's an easy question. I think this FMG was very easy. I think so. Okay. Which of the following correctly describe the phenomena of vasomotor reversal of Dale? Yes, good, Wasim. Now can you answer? All my dear students. Which of following correctly describe the phenomena of vasomotor reversal of Dale? Yeah. Here the answer is Dr. Metroy. Your answer C. Okay. Now look at it. Describe phenomenon of vasomotor Dale's vasomotor. Repeated administration of ephedrine decreasing its effect on BP. High dose acetylcholine. Okay. Increasing pulse pressure. Okay. A patient pre-treated with phenethylamine develops severe hypotension. Yes, good, Dr. Metroid. Alpha blocker point. Yes, good. This answer, very good. So, this answer, good. Why? I explain. Usually, the Dale's vasomotor reversal phenomena studied with our adrenaline. Okay, so here don't talk about ephedrine, don't talk about acetylcholine. It's mainly with the adrenaline. That means what? Look what they say. Normally, adrenaline acting on alpha 1, alpha 2, beta 1 and beta 2. But exactly speaking, this is in high concentration, adrenaline mainly acting on alpha 1. In low concentration, adrenaline mainly acting on beta 2. Other action not that much significant. In high doses, in high concentration, it acting mainly on alpha 1. In low concentration, acting mainly on beta 2. With this first point, if I give adrenaline, if I inject adrenaline, once I inject, initially the high dose, in high level, it is acting on alpha 1, causing vasoconstriction, thereby increase in BP. As time passes, the drug level decreases. When decreases in low concentration, it's going to act on beta 2, causing vasodilatation, thereby causing fall in BP. So look at adrenaline initially causes, look at adrenaline initially causes rise in blood pressure, later on fall in BP. The initial rise is due to alpha 1 action, later fall is due to beta 2 action. This is known as biphasic. It's called biphasic response of adrenaline. It is called biphasic response of adrenaline. Now I want to experiment. For example, my experiment number 1. If I give first, I give alpha blocker. I blocked all the alpha receptor and then I give adrenaline main. Now I blocked all the alpha. After blocking alpha, if I give adrenaline, now the adrenaline straightway going to act only on beta 2. By acting on beta 2, it causes only fall in BP. This experiment is known as Dale's vasomotor reversal phenomena. That means in your question, look at this. A patient pre-treated with phentolamine. It's an alpha blocker, non-selective alpha blocker, followed by given adrenaline and developed severe hypotension. This is called Dale's vasomotor reversal phenomenon. So remember, first we give alpha blocker and then we give adrenaline, we get only fall in BP. Whereas my next point, keep in mind this also. If I give first, my second experiment, if I give first beta blocker and then if I give adrenaline main, my adrenaline now going to act only on alpha 1. By acting only on alpha 1, it causes only increase in blood pressure. This experiment is known as re-reversal of Dale's phenomena. Re-reversal. So in re-reversal, first we give beta blocker. Whereas in your question, the Dale's vasomotor reversal, first we give alpha blocker. This is what your question. Okay. Next. Which of the following statement is correct regarding the mechanism actions of labetalol? Very simple. Labetalol mechanism action. This type of question and all, when you see the drug, you should come to mind the mechanism before seeing the option. We know any drug name ending with the lol mean they call beta blocker. But one special point, labetalol not only blocking beta, it also have additionally alpha blocking property. With this in mind, look at option. The answer will be option number A. Blocks both alpha and beta receptor. Very good. All are doing very good job. Fantastic. Now, Based on this, you should also know some extra point. For example, this keep in mind, sometimes useful. Okay, based on the action, a beta blocker. If a beta blocker having some extra property, if beta blocker having some extra action, mean they call third generation beta blocker. We have first generation, and then we have second generation and third generation. Third mean a beta blocker having some additional property. For example, there are some beta blocker having additionally alpha blocking property. For example, labetalol and carvedilol. So here in your paper, the question was, what is labetalol? It's a beta plus alpha blocker. So beta plus alpha blocker useful for hypertension and hypertension emergency. That you know. And the most important adverse effect causing postural hypotension and hepatotoxicity. And look here, we have one thing called carvedilol. It is also a beta plus alpha blocker, but extra point, it having additionally antioxidant and anti-inflammatory action and calcium blocking property also. Here the very important point, this drug very useful for hypertension and congestive cardiac failure. This is what most important. Okay. And just for clearing FMGE, if you know this and this enough, but keep in mind, bucindolol, biventolol, niprodil also having beta plus alpha blocking property. And there are some beta by having nitric oxide releasing property. For example, nebivolol, celiprolol, and then we have something called cortiolol. Then, can you please answer Urvashi Chaudhary or Matroid Wasim Ahmad? Can you please name any beta blocker having additional action of opening potassium? Beta blocker potassium opening property. That's called tilizolol. And then beta blocker having potassium blocking action is sotalol. This again important. Sotalol, a beta blocker with the potassium blocking. That's why potassium opening mean tilizolol. Potassium blocker means sotalol. Okay, Dr. Metroid. Sotalol is a beta blocker with the potassium blocker. That's why this only one beta blocker comes under class 3. Comes under class 3 anti-arrhythmic agent. Usually all the beta blocker comes under class 2, whereas sotalol comes under class 3. And beta blocker having calcium blocking properties are we having carvedilol and betaxolol. Like that we discussed in our classroom what are the third generation. They asked about one thing called what is the mechanism of action of labetalol. Answer, so beta plus alpha blocker. This simple question asked. Okay, next. A 70-year-old male with benign prostatic hypertrophy and symptoms of urinary urgency is the best controlled by what? Say a man, elderly male with BPH, for giving symptom relief for this patient. Yeah, very good, Aru. The answer tamsulosin. Good. Tamsulosin is highly selective alpha 1A blocker going to cause urethral sphincter, internal sphincter relaxation, thereby relieving the symptom. Very good. Answer A. So just look at the image. In a benign prostatic hypertrophy patient, to relieve the symptom, we have to go for two things. What two things? For example, look here. The enlarged prostate constantly compressing urethra, that is called static obstruction. Whereas alpha 1 in the sphincter causing dynamic sphincter constriction called dynamic obstruction. So there's a dynamic as well as static obstruction. Thereby patient having difficulty in urination. To relieve this problem, I have to overcome both the components. For that, I can go for combination of finasteride plus tamsulosin. So treatment for BPH means combination of finasteride plus tamsulosin. What is finasteride? Finasteride is the 5-alpha reductase enzyme inhibitor. thereby inhibiting conversion of testosterone to dihydrotestosterone. The dihydrotestosterone, DHT, it is the one causes prostate enlargement. So, the static obstruction relieved by finasteride. Finasteride reducing size of prostate, whereas tamsulosin is a alpha 1A blocker that going to overcome the dynamic obstruction. Good. Dr. Medroids relieves dynamic component of BPH. Very good answer, man. So, question: tamsulosin, a alpha 1A blocker that going to give rapid symptom benefit, that means overcoming dynamic obstruction. Of course, you should know tamsulosin among the two drug one, among the finasteride tamsulosin, which one give rapid symptom relieving? It is tamsulosin. Whereas the size of the prostate reduced by what drug mean? Finasteride. And to reduce the size of prostate, finasteride takes at least about 3 to 6 months. So, for rapid symptom relief in BP patient, go for tamsulosin, which is alpha 1A blocker acting on internal urethral sphincter. Okay. Next, a female 20-year-old age coming to OPD with the complaints of dropping of eyelid in the evening time. This patient almost symptom free in the morning, and the muscle weakness increases during evening time. As a physician, you have noticed that patient symptom improve after using neos treatment. What may be the most appropriate diagnosis? See, this is a simple question. A female patient drooling of eyelid, ptosis, weakness relieved by using neos treatment. Neos treatment, one of the cholinergic drug, anticoagulants. So, automatically answer will be myasthenia. Very good. Already good job. Fantastic. Myasthenia. Now here, just look at this. Actually, myasthenia gravis, one of the autoimmune disease. Here, very important point. What you should keep in mind is, look here. Laddu question. Wow, good. So, myasthenia gravis, autoimmune disease. Here, look at this. There's an autoantibody formed against postsynaptic cholinergic receptor, that is NM receptor. So the pathology located postsynaptically. Okay, and for treating this condition, we have to increase level of acetylcholine. For that, we go for anticholinesterase. Now, the most preferred anticholinesterase for treating myasthenia, we go for either neostigmine or pidostigmine. They given in your question neostigmine. So, a muscle weakness patient, symptom relieved by neostigmine, most probably it's a case of myasthenia gravis. Straightforward. In this junction, can you answer Wasim Ahmad? Name one anticholinesterase useful for diagnosis of myasthenia gravis. See, for treating, you can use neostigmine or pidostigmine. Mostly we go for pidostigmine because orally given drug and having long in duration action. So, patient will prefer to go for pidostigmine. My question, name one anticholinesterase useful for diagnosis of myasthenia. Yeah, very good. That is called hydrophonium, also known as tensilon test. Hydrophonium, one of the very shortest acting anticholinesterase, rapidly undergo renal route of excretion. So, very shortest acting. This is when you give, if the symptom relieved immediately mean the diagnosis, most probably it is a case of myasthenia. Called hydrophonium test, also called tensilon test. Very good, very good. Next. Here one more point you should know. You know what is myasthenia, but remember what do you mean by Lambert-Eaton syndrome? That's also important question. Look here. Imagine it's a cholinergic neuron. From the neuron, there's a release of acetylcholine. Acetylcholine acting on nicotinic on the muscle. And we studied an antibody against NM receptor causing muscle weakness. That's called myasthenia gravis. Where is my question? Look here. Look at the neuron. In the neuron, here, we have one channel called calcium channel. Whenever through the channel calcium enter, when calcium enter, the calcium will promote the release of acetylcholine. My question is, if there's a defect in the calcium channel, if the calcium not entered properly, means there's no proper release of acetylcholine, thereby also muscle become weak. This is known as Lambert-Eaton syndrome. So this you should know. One, what do you mean by Lambert-Eaton syndrome? For example, imagine it's a cholinergic neuron. Imagine a vesicle. In the vesicle, there is a storage of acetylcholine. I told that in the neuron, there is one calcium channel. When the calcium enters through channel, the calcium will pushes the vesicle down and causing vesicle rupture. Thereby, acetylcholine get released. The released acetylcholine will act on nicotinic on muscle. It's a normal physiology. If there is a defect in the calcium channel, calcium will not enter properly, thereby no proper release of ACH, there is no proper muscle contraction, mean that's called Lambert-Eaton syndrome. Here my question starts. Anybody? For treating this syndrome, I have one drug. Name the drug. That is called 3,4-diaminopyridine. 3,4-diaminopyridine, also known as dalfamidine. This is going to promote the calcium entry. It's a calcium channel activator plus potassium overlap. It's a calcium channel activator, thereby promoting calcium entry, promoting AC release. And extra points at the dalfamidine not only useful for treatment of Lambert-Eaton, it is also useful for treatment of multiple sclerosis. Here, the drug going to improve the walking capacity. The purpose of using dalfamidine in MS patient is to improve walking capacity. That's the extra point. Now look at the question. Drug providing relief from cardiac remodeling and increasing the longevity of life. Answer: metoprolol, torsemide, prazosin, furosemide. Come on. For treating the heart failure, we have some drug useful only for symptom relief. Some drug going to modify heart disease. They call disease modifying drug. Now what is the answer here? Here the answer is metoprolol. Good. Beta blockers are disease modifying drug useful for heart failure. Whereas torsemide, furosemide, these two are loop diuretic. The loop diuretic useful only for symptom relief. Prazosin, alpha 1 blocker, this can be tried but only for symptom relief. So my answer for this question, option A, metoprolol. So the key message is for treating heart failure. For example, in acute heart failure, that is acute failure, sudden onset of heart failure. Here, suddenly there's a risk of pulmonary edema. Here the patient will present with severe breathlessness. So for treating the breathlessness, we want to use symptom relief. For giving symptom relief, we use some drug. For the mnemonic, we have 3 Ds. 3 Ds. What 3D? For example, diuretic like furosemide, or dilators like neseritide, or nitrates, and inotropes. Inotrope like digoxin, or dopamine, or dobutamine. All these are increasing force of cardiac contraction. All these are called symptom relieving agent. Okay. So question: for acute heart failure, we just want to relieve the breathlessness, just want to use symptom relief. For that we use diuretic like furosemide, dilators like nesritide or nitrates, and inotropic drug like digoxin, dopamine, dovidum, metriates, milrinone. Yes, you are right. Milrinone is one of the inodilator. Usually we don't use this nowadays because they cause more of side effects. So all these are comes under phosphodiesterase 3 enzyme blocker like amrinone and milrinone, but they cause so many adverse effects. We don't prefer that in treatment of heart failure. Okay, now it's called symptom relief. Whereas in chronic failure, I mean, there's a gradual left ventricular failure. Because the gradual failure, there are some compensatory changes coming into play. The compensations are number one, sympathetic action, catecholamine, or else can say sympathetic activity. One more compensation, activation of RAS system, renin-angiotensin system. Because of the compensation, what happened? The sympathetic stimulation acting on beta 1, that causes increasing heart rate, increasing force of contraction. It may acting on alpha 1, causing vasoconstriction. See, increased contraction, increased heart rate, and increased vasoconstriction, all these are causing stress on the heart. Even RAS, renin-angiotensin. See, angiotensin 2 and all powerful vasoconstrictor. Aldosterone causing sodium water retention. So, the activation of compensatory system causes more of ventricular stress. This resulting in ventricular remodeling. That's why your question, which is the drug useful to prevent the remodeling and going to promote the longevity of life, mean those blocking this compensation. That means those blocking the sympathetic system. That's called beta blocker. Or those blocking RAS, called RAS blocker. That means, look at this, the beta blocker, RAS pathway blockers, the so-called ACE inhibitor, ARBs, and mineralocorticoid receptor antagonist, the so-called aldosterone receptor blocker. All these are called disease modifying drugs useful for heart failure. So in summary, what I want to say, there are some drugs reducing mortality, going to improve the lifespan of the patient. They call disease modifying drug. Who are they? Beta blocker and RAS blocker. RAS blocker means ACE inhibitor ARB. In this junction, can you answer Medroid or Wasim or somebody can answer? Name one ARB available with the fixed dose combination with the sacubitril. Name any one ARB available as a fixed dose combination with the sacubitril. For example, we have one thing called combination of valsartan. Valsartan is one of the angiotensin receptor inhibitor. Sacubitril, one of the neprilysin inhibitor. This is available as a combination that is called ARNI. ARNI means yes, good, mad, right, very good. Valsartan, sacubitril, it's called ARNI. ARNI means angiotensin receptor and neprilysin inhibitor. Good. And another question, can you answer? I have told that beta blocker useful as a drug for heart failure, going to improve the lifespan. Now question, which are the beta blocker approved to improve the lifespan in patient heart failure, or which are the beta blocker approved for treatment of CCM? The most important beta blockers approved for treatment of CCFR. Number one, carvedilol, then bisoprolol, then metoprolol, and then nebivolol. This is the four most important beta blocker approved for CCF. In this, most important drug is carvedilol. Of course, aldosterone antagonist. We have in spironolactone and ivapadine. So funny current sodium blocker. It is also useful for heart failure. Apart from this, ah, wait, Dr. Medya, please wait. Now just I'm telling heart failure. Okay, and your question, say for look at this. The question was look here. Whenever you're using beta blocker in heart failure, be careful. Be careful because the beta blocker decreasing cardiac force of contraction. Because of decreased force of contraction, they may reduce cardiac outputs. That's why be careful in class 3 and class 4 failure. In fact, better avoid this in class 4 and class 3 failure. First, stabilize them and then you can start using. First, stabilize them. Okay. If at all you want to use them, better use them in class 1 and class 2 failure. If here stabilize the patient and then think of using beta blocker. And one more point, whenever you want to use beta blocker, first thing start them with the low dose, gradually increase the dose to optimal level. Because when you go suddenly high dose, they may cause sudden severe reduction of force of contraction, may further worsen heart failure. Okay, Dr. Madjot, are you satisfied? Okay, now the last question, look at this. We have one thing called combination of isosorbate nitrate plus hydrazine. This combination is very useful for treatment of CCF, especially in African American population. Combination of ISDN, isosorbate dinitrate plus hydrazine useful for treatment of heart failure in African American population. Okay, next. Which is the drug acting on letter mentioned 2 in this diagram? Here 1, here 2, here 3, 4, 5 like this. So asking what is acting on 2? 2 mean what? Inhibition of conversion of angio to angiotensinogen into 1. It is blocked by aliskiren. Answer is option number C. Okay, I'll show this. This picture indicate ROS pathway blocker. ROS pathway blocker. Okay, now I'll discuss. Look here. When I say ROS, renin angiotensin aldosterone system blocker, please remember in the kidney we have beta 1. The beta 1 receptor seen on heart and kidney. The function of beta 1 in the kidney is causing renin release. The renin action is conversion of angiotensinogen into 1. And then the angiotensin 1 will be converted into angiotensin 2 by angiotensin converting enzyme. The angiotensin 2 going to act on adrenal gland and causes release of aldosterone. It's a ROS pathway. Now just go one by one. A drug going to inhibit renin release. Renin release inhibitor is beta blocker. Next question. Renin action. Renin action is conversion of angiotensin to 1. The action of renin blocked by direct renin inhibitors. They are aliskiren, remikiren, inakiren. Aliskiren, remikiren, inakiren. They call direct renin inhibitors. And then angiotensin 1 converted into 2 by the help of ACE. Those drug blocking this, they are called as ACE inhibitor. Now you can say enalapril or captopril, those end with the pril. Okay, and then angiotensin action at the receptor level blocked by something called ARBs, like losartan, valsartan, like this. And then can you answer? Name the drug blocking the aldosterone action. I want aldosterone antagonist name. Answer please. The example for aldosterone antagonist are we having spironolactone, candrenin, eplerin. All these are aldosterone antagonist, or you can say them potassium sparing diuretic. Spironolactone, candrenin, eplerin. Here extra point. Candrenin is an active metabolite of spironolactone. Okay. Next. Find out the site of action of thiazide. Come on. I given nephron picture. I given number 1, 2, 3, 4 like this. In this picture, what is the site of action of thiazide? Thiazide is a group of diuretic acting on distal convertible. That means site is answer number 3. Okay, that is C. Okay. Now just to go one by one. In the PCT, we have carbonic anhydrase enzyme activity. So carbonic anhydrase enzyme inhibitors. Carbonic anhydrase enzyme inhibitor acting on PCT. For example, acetazolamide. Then in the loop of Henle, in ascending limb of loop of Henle, here loop diuretics. Ascending limb of loop of Henle, thick ascending limb. And in the DCT, going to be thiazides. And then collecting ducts. Drug acting on collecting ducts are potassium sparing diuretic, like spironolactone. Okay, so here the answer is option C. I'll give extra point also for you. Look at this. If we study the nephron picture, in the PCT, some drugs are acting. They're called as carbonic anhydrase enzyme inhibitor like acetazolamide. Then in loop of Henle, for example, in the thick ascending limb of loop of Henle, some drug acting, they called as loop diuretic like furosemide or torsemide like this. Some of the diuretic acting on distal convertible, they are called as thiazide diuretic, inhibiting sodium chloride imports. And then collecting ducts. In the collecting duct, some of the diuretic, they are called as potassium sparing diuretic. Again question, a potassium sparing diuretics are two types. One type is called epithelial sodium channel blocker. For example, amiloride acting on collecting ducts. Other group is aldosterone receptor blocker. Aldosterone receptor blocker. For example, we are having something called spironolactone, candrenin like this. Okay. And extra, only one extra point. Osmotic diuretic, they acting on loop of Henle, like descending limb of loop of Henle. Okay, that's about site of action based question. Next, dicumarol mechanism action. Come on. Dicumarol is a derivative, something similar to warfarin. It's also called warfarin. Now tell me, what is the mechanism action of warfarin? Warfarin is an oral anticoagulant acting against vitamin K. So inhibiting vitamin K dependent clotting factors. Good. Now look at the point. When you say warfarin mechanism action, what we teach in classes? Warfarin, first point, inhibiting vitamin K epoxy reductase. Because of inhibiting vitamin K epoxy reductase, ultimately inhibits gamma carboxylation of vitamin K dependent clotting factors. Inhibiting vitamin K dependent clotting factors. The vitamin K dependent clotting factors are 2, 7, 9, 10. So in your exam, the question was warfarin mechanism of action is acting by inhibiting vitamin K dependent clotting factor like 2, 7, 9, 10. That's the answer. Extra point main, look here. We know warfarin inhibiting vitamin K dependent factor like 2, 7, 9 and 10. Here just to look at the half-life. Look at the half-life of the vitamin K dependent protein. 2 having half-life of almost to 70 to 70 hours, almost to 3 days. 7, 4 to 6 hours. 9, 20 to 24 hours. 10 is about 40 to 44 hours. That means what I want to say, the short half-life is factor number 7. Short T of. So, the first factor decreased by warfarin is factor number 7 because short half-life. Whereas the factor 2 having longest half-life. Longest. That means the last factor decreased by warfarin, factor number 2. Okay. And again, to inhibit all the factor, warfarin takes about 72 hours. To inhibit all factor, it takes about 70 hours. That's why warfarin having lag period, therapeutic delay, lag period of 3 days. That's why warfarin not used for emergency. It is only for prophylactic purpose. Warfarin used only for prophylactic purpose. Now the question to all people, come on. Warfarin, in addition to inhibiting 2, 7, 9, 10, can you tell me, name some other factor which also depends upon vitamin K. That is, not only 2, 7, 9, 10, even protein C and protein S also vitamin K dependent protein. If these also vitamin K dependent factor mean my warfarin going to inhibit this also. Here one point you should know, the protein C. Protein C normally protein C will inhibit factor 5 and 8. Normally protein C will inhibit factor 5 and 8. Now tell me, warfarin going to inhibit protein C mean the factor 5 and 8 level may increase. That may cause hypercoagulation and skin necrosis. So look here, warfarin may cause adverse effect of hypercoagulation and skin necrosis, sometimes purple color toes, called purple toe syndrome. This is also important. Warfarin may cause hypercoagulation, dermal necrosis and purple toe syndrome, possible due to inhibition of protein C. Protein C that causes elevation of factor number, look at side, factor number 5 and 8. Because of elevating 5 and 8 level, it causes this complication. This you should know. Okay, good matriarch, good. Definitely all of you are going to get a good rank. Good. Okay, good. Now look here. Which of the following anti-dyslipidemic drug work by stimulating the PPAR alpha? Options are gemfibrozil, simvastatin, ezetimibe, cholesterol. What answer? Gemfibrozil is a fibrates. Fibrates are activating PPAR alpha. Okay, so answer is option number A. Statins are inhibiting FMGE reductase enzyme. Ezetimibe inhibiting cholesterol absorption from the intestine. Cholesterol is a bile acid binding resin which also inhibit cholesterol absorption from intestine. Now, I just explain in my own style. Look at me. For example, we have one group of drug called statin. Statins are wonderful drug, mechanism action, inhibiting FMGE reductase enzyme, thereby inhibiting cholesterol synthesis. So total cholesterol in the plasma getting fall. Point 1. Point 2. Whenever I give statin decreases cholesterol synthesis. Thereby what happens? The liver cells causes upregulation of LDL receptor. Because of upregulation of LDL receptors on the liver cells, what happened? The peripherally running LDL will be engulfed by the receptor. When LDL engulfed by receptors, the peripheral LDL level get decreases. That means the two main actions of statins are decreasing plasma total cholesterol level and decreasing plasma LDL level. It's mechanism action. Now, in your question, the question was, they asked about which is the cholesterol lowering group of drug acting as a PPAR alpha. The answer is fibrates. PPAR means peroxisome proliferated activated receptor. We have PPAR alpha and gamma. See, fibrates are PPAR alpha agonist. Thereby, they stimulate lipoprotein lipase enzyme that in turn decreases TGL, triglyceride, the so-called VLDL. That means fibrates or PPAR alpha activator useful for reducing triglycerides. Whereas we have one group of drug called PPAR gamma activator. Here the PPAR gamma causes insulin sensitization. PPAR. Please remember, PPAR gamma causes insulin sensitization, thereby reducing blood sugar. That means we have one thing called pioglitazone, called PPAR gamma agonist, useful for treatment of diabetes. Okay. Now, can you answer Madroids? One easy question. PPAR alphas are useful for lowering cholesterol. PPAR gamma pioglitazone useful for diabetes. My question, can you tell me one? We have one thing called PPAR alpha and gamma agonist. Name any one drug having both alpha and gamma action. For example, saroglitazar. This drug have both action. Because yes, good. Saroglitazar, good. Because of this action, it is useful for as a alpha useful for lowering lipids, as a gamma useful for diabetes. That means approved for treatment of diabetic dyslipidemia. Useful for treatment of diabetic dyslipidemia. Very good, very good. Next, we have one thing called niacin. Niacin is a vitamin. It is also having cholesterol lowering property. It is acting by inhibiting lipolysis. So question, find out the vitamin having cholesterol lowering action. Think of niacin inhibiting lipolysis. In fact, it's a very good drug lowering LDL, lowering LPA cholesterol, and very, very, very important, increases HDL. Among the cholesterol lowering drug, a drug going to very much increases HDL, mean that is niacin. Okay, and then very interesting. I'm going to talk about acetamib. Look here. Imagine the intestine. Imagine the liver. Now look here. A patient wants to take a cholesterol diet. The cholesterol now goes inside the intestine. From the intestine, cholesterol now getting absorption like this. The absorption of cholesterol can be blocked by one thing called acetamib. Acetamib inhibits cholesterol absorption. Acetamib actually inhibits NPC1L1. That is Niemann-Pick C1L1 channel, through which cholesterol getting absorption. the absorption of cholesterol from the intestine blocked by ezetimibe. Ezetimibe acting by blocking NPC1L1, Niemann-Pick C1L1 channel, thereby inhibiting cholesterol absorption. Similar to this, look at this. We have something called bile acid sequestrants. Come on, look here. The bile acids once get released from the liver, they goes to intestine. If the patient taking cholesterol diet mean, the cholesterol goes to intestine, the bile acid going to bind with the cholesterol and causes cholesterol absorption. So for the absorption of cholesterol, bile acid helping. Now I want to prevent the absorption of cholesterol. For that, I have something called bile acid sequestrants. For example, look here. I have some drug like cholestyramine, cholestyramine, cholesavalum. These are called bile acid sequestrant. If I give any one of these drugs, these drug will go and bind on bile acid. By binding with the bile acid, they don't allow the bile acid to bind on cholesterol, thereby cholesterol not allowed for absorption. So these drugs also inhibit cholesterol absorption from the intestine. They call bile acid sequestrants. Okay. In this junction, can I please answer anybody who does a live chat? Please answer. Among the three drugs, which drug got approval for treatment of diabetes? Type 2 diabetes. Name the bile acid sequestrant got approval for diabetes. It is cholesavalum. It is a cholesterol lowering drug. Also got approval for treatment of type 2 diabetes. Okay. Next. This is another very interesting question. Look here. We know statins reducing total cholesterol and LDL. The LDL cholesterol was reduced because statin causes upregulation of LDL receptors. Look at the point. The LDL receptors may undergo degradation by one group of enzyme called PCSK9. The PCSK causes degradation of LDL receptor. When they go for degradation, the plasma LDL may not be controllable. So to avoid that, we have something called PCSK9 blocker. PCSK means proprotein convertase subtilixin kexin. So we have some PCSK9 blocker. They are called alirocumab and evolocumab. This is another very important. Alirocumab, evolocumab are PCSK9 blocker useful for lowering LDL. A monoclonal antibody useful for lowering LDL cholesterol, alirocumab and evolocumab. Good. A female patient having pain in her great toe, that is metatarsophalangeal joint, having swelling, redness. She was treated with a proper drug therapy, but her uric acid still coming out be very high. Which of following drug can be given for fast elimination of drug from the body? Here they want name the uric agent. That's all they want. Okay, answer is very good. Option number D. See, allopurinol is xanthine oxidase inhibitor, reducing the synthesis of uric acid. Febuxostats are same mechanism. Allopurinol, febuxostats are xanthine oxidase inhibitor, reducing uric acid synthesis. Colchicine, a drug inhibiting microtubules of neutrophil, thereby preventing chemotaxis, preventing inflammation, useful for acute gout. Probenecid is a uric agent. So answer option D. And just for explanation, look here. In case of hyperuricemia, here they want a drug to promote uric acid excretion. But actually speaking, for treatment of hyperuricemia, we have two options. One option is either we can inhibit synthesis of uric acid, or we can promote excretion of uric acid. Those drug promoting excretion of uric acid, they are called uricose uric agent. This is what your question. And just for completion purpose, I'm telling the most important two drug inhibiting synthesis of uric acids are xanthine oxidase inhibitor, the so-called allopurinol and febuxostat. The allopurinol and febuxostats are xanthine oxidase inhibitor inhibiting synthesis of uric acid. Whereas this is also very important point. We have something called 6-mercaptopurine, one of the anti-cancer drug. Azathioprine, one of the immunosuppressant. Both the drug undergo metabolism by xanthine oxidase. So question, when you are using allopurinol with 6-MP, can you please answer Dr. Medrioid or Wasim or somebody? Can you please answer? I am telling 6-mercaptopurine, anti-cancer drug, azathioprine, one of the immunosuppressant, both are normally undergoes metabolism by xanthine oxidase. Suppose if we want to use allopurinol with 6-mercaptopurine, what happened to the plasma level of 6-MP? If we give allopurinol with 6-MP, what 6-MP? 6-MP level may get increased. Very good, very good, very good. So 6-MP level increase. So reduce the dose of 6-MP. 1/3 dose reduction must. Very good, my dear. Very good. Good. Now you know xanthine oxidase inhibitor name. Whereas the drug causing uricose uric actions, those promoting excretion of uric acid, they call probenecid, sulfenpyrazone, benzbromarone, and lesinurad. We have probenecid, sulfenpyrazone, benzbromarone, and lesinurad. Here they ask about this question. Okay, but again you should remember probenecid can be added with penicillin for what purpose? Penicillin undergo excretion through kidney by tubular secretion. This can be blocked by adding with probenecid. That means probenecid can prolong the duration action of penicillin. That also important. Okay. In this junction, can you please answer? Anybody who is a live chat can answer. Name any one calcium channel blocker having uricose uric action, or name one ARB having uricose reaction. Cancel. For example, we have losartan, ARB, amlodipine, a CCB, fenofibrate, a fibrate group of cholesterol lowering drug. They also having uricose uric property. That means good, fantastic. That means for treatment of hypertension with gout, in this patient, find out the preferred CCB mean, go for amlodipine. Find out the ARB very suitable for treatment of hypertension with gout mean, go for losartan. So the losartan and amlodipine, the fenofibrate, they are all having uricose uric property. And last one point, see, the uric acid undergoes metabolism by one thing called uricase enzyme. So to promote the metabolic breakdown of uric acid, we have something called uricase analog. They are going to increase uric acid metabolism. They call uric acid metabolism enhancer. For example, rasburicase, pegloticase. They are used intravenously for aggressive control of uric acid. So rasburicase, pectoticase or uricase analogs. Okay. Next, a female patient was having pain in grade 2 with swelling and redness. Her uric acid level was high. She was treated with a proper drug therapy and her symptom was subsided. The drug that reduced uric acid level must be acting by what mechanism? Okay, I think there's two questions from gouty arthritis. Here the concept is they give an option xanthine oxidase inhibitor. Other option HP, that is hypoxanthine guanine phospholipase ribotransferase inhibitor HPRT. Okay, so answer automatically xanthine oxidase inhibitor. Okay, other option is incomplete, but anyway, answer is xanthine oxidase enzyme inhibitor. A 20-year-old girl presented to hospital with a mild fever, night sweating, won't take up full efficient, and adenosine deaminase level was raised. Which are following first line anti-TB drug that are used in the treatment regimen for initial 2 months of the patient? See, here the answer will be first line drugs today. Only 4: isoniazid, then rifampicin, pyrazinamide, and ethambutol. They are the first line drug in today era. So, straight question, go for option ethambutol. Streptomycin not considered the first line drug. Nowadays it becomes second line only. So, among the given option, best is option B. A patient suffering from rectal carcinoma on chemotherapy developed severe profuse diarrhea. Which of the following drug can be given to control this diarrhea? See, chemotherapy diarrhea. Okay, it's a not infective diarrhea, it's a non-infective, diarrhea. For these cases, we can very well try anti-motility agent. Okay, option we have loperamide, atropine, octreotide, ofloxacin. I think this I put option, but exact what they give I don't know. Here the most probable answer go for loperamide. Loperamide, one of the opioid, very commonly useful for treatment of non-infective diarrhea. So better go for loperamide. Okay. Octreotide is somatostatin analog. It is mainly useful for treatment of secretory diarrhea. For example, carcinoid, tumor diarrhea. Okay, ofloxacin useful for treatment of infective diarrhea. Like this. So answer is option A. In this I will tell extra point regarding loperamide. Look here. For treatment of non-infective diarrhea, we can try opioids. Among the opioid commonly used drugs for treatment diarrhea, because anti-diarrheal opioids of giving loperamide, difenoxylate, and difenoxin. In your exam, they given loperamide. That's the best answer. Here, extra point after the loperamide and difenoxylate both are commonly used anti-diarrheal opioid. Here, loperamide does not cross blood-brain barrier, so no risk of addiction. Whereas difenoxylate can crosses the blood-brain barrier, so having risk of causing addiction. Now, to control the addiction, we can add one thing called atropine. So they say atropine can be added with the difenoxylate to prevent addiction of difenoxylate. How atropine going to reduce addiction? That mechanism is not clear, but you should know which drug added with the difenoxylate to prevent addiction mean answer atropine. And next point, we have one drug called newer opioids like ilixadolin, asimidolin. they also useful for treatment of diarrhea. So find out the newer drugs mean, think of ilixidolin, asmidolin. An extra one point, rasigadotil. Rasigadotil is also opioid. Exactly speaking, it is called encapsulinase enzyme inhibitor. Going to accumulate encapsulin, thereby control diarrhea. Rasigadotil. Okay. And coming to octreotide, octreotide is a somatostatin analog useful for treatment of carcinoid diarrhea. That's the drug of choice. For this diarrhea, drug of choice is octreotide. It can be combined with the telotristat. Telotristat, a newer drug. This drug going to inhibit synthesis of serotonin. So serotonin synthesis inhibitor can be combined, but drug of choice is octreotide. Next, drug useful for chemotherapy-induced nausea-vomiting. See, most of the anti-cancer drug causing severe nausea-vomiting. To treat the vomiting due to cancer chemo, what is the best anti-emetic combination? Options are granisetron, dexa plus aprepitant. Option B, dexa plus metoclopramide plus domperidone. Option C, prochlorpromazine, granisetron, domperidone. Option D, doxylamine, granisetron, aprepitant. What is the answer? The right answer is very good. Option number A. Granisetron, a 5-HT3 antagonist. Dexa is steroid. Aprepitant, neurokinin 1 antagonist. This is the best combination among this given option. So just I will refresh your point. See, actually, for treatment of chemotherapy drug-induced vomiting, the best choice will be the anti-emetic choice will be 5-HT3 antagonist like ondansetron or granisetron or tropisetron or dolasetron or palnosetron. Okay, they are the best anti-emetics for controlling vomiting due to anti-cancer. Here, palnosetron, the highly selective 5-HT3 antagonist, and it has a longer half-life. Half-life is about 40 years, longer half-life. An extra old question, the dolasetron may cause side effect of QT prolongation. One more old point, ondansetron, famous drug that causes most commonly what side effect? Headache. It's the most common side effect. Now, the 5-HT3 blockers are the primary anti-emetics for treatment of vomiting due to cancer chemo. But for a better control of vomiting, along with the 5-HT3 blocker, we add some adjuvants, some adjuvant anti-emetic. So the supportive, for better efficacy, some supportive anti-emetics are added with the 5-HT3 blocker. They call adjuvants. For example, D2 blocker, dopamine, D2 blocker like domperidone or metoclopramide, or benzodiazepine like diazepam, or steroid like dexa. Dexa is a very fantastic anti-emetic agent. So we go for combination of 5-HT3 blocker plus dexa. And one more point you should know, a vomiting in chemo patient can be early phase vomiting. One more thing, late phase vomiting. Early mean immediately following chemo vomiting. Late phase mean vomiting after 24 hours or after 48 hours. So late phase. For treating the late phase vomiting, the best anti-emetics are. For late phase vomiting, best anti-emetics are aprepitant, fosaprepitant, rolapitant, NEETPG. All these drugs named NEETPG. They are called neurokinin 1 antagonist, NK1 blocker, the best. That's why in general, what I say, in general, for having a good anti-emetic action, better go for combination of one 5-HT3 blocker plus DEXA plus one NK1 antagonist. This combination is a very good combination for better control of vomiting, early phase or late phase, whatever, best. Extra point, all these drugs are longer acting drug, but you should know we have one drug called Pelenosartan. Among the 5-HT3 blocker, it is the longest acting agent. So this is also useful for late phase vomiting. So question can be, which is the 5-HT3 blocker very good for treatment of late phase vomiting? Mean answer Pelenosartan. One extra point, we have one drug called Olanzapine. It is actually speaking atypical antipsychotic. This is also having very good anti-emetic action, useful for treatment of chemo-induced vomiting. So new point. Next, a 30-year-old college professor suffering from depression comes to you with the complaints of unable to get involved in process of intercourse with his wife. Which are following antidepressant best to be prescribed for him? See, most of the antidepressant causing sexual side effect. So for this gentleman, what you want to use? Options are escitalopram, bupropion, venlafaxine, imipramine. Come on, Madriots, Wasim, other my dear friends, can you please answer? What may be the answer for this question? Look here. Escitalopram, one of the SSRI. Bupropion is an NDRI. Venlafaxine, SNRI. Imipramine, tricycle antidepressant. Okay, look here. Most of the drug, those increasing serotonin causes sexual dysfunction. So SSRI, SNRI, TCA, all this definitely having sexual dysfunction. So they're not good for him. Here best to go for bupropion. That's best NDRI. Okay. In fact, SSRI causes adverse effect of delay in ejaculation. In your question, the right answer option B. But in general, I'll teach you one thing. Yes, antidepressant and sexual dysfunction. For example, SSRI causes adverse effect of delay in ejaculation. But keep in mind, because of causing this adverse effect, the SSRI can be useful for treatment of premature ejaculation. Then, we have one drug called trazodone. It is one of the atypical antidepressant. It causes priapism. It causes side effect of priapism. Because of causing painful penis erection, it is useful for treatment of erectile dysfunction. But what Goodman-Gilman says, this drug having lowest risk of sexual dysfunction, mirtazapine. So question, less sexual mirtazapine. It has least sexual dysfunction. Okay, but coming to your options, look at this. We have one thing called SNRI. For example, venlafaxine, duloxetine. All are SNRI. They also causing adverse effect of sexual dysfunction. Anything going to increase serotonin level will cause sexual dysfunction. Duloxetine use is also important. Duloxetine, one of the SSRI, useful for treatment of depression, also useful for diabetic neuropathy, useful for fibromyalgia and to control urinary stress incontinence. Suppose a female telling, even coughing, even laughing, causing urination, to control that we can try duloxetine. And finally, what about bupropion? Bupropion, one of the norepinephrine dopamine reuptake blocker. It's a very fantastic antidepressant, useful for treating depression. But extra interesting question, it is useful to control smoking. The other uses useful to control smoking habits. It also useful in ADHD management, also useful for managing obesity. It was weight loss, useful for treatment of obesity. The adverse effect of these drugs may cause anxiety and seizure. Anxiety problem and seizure problem. So in your question, answer will be prepared. Next question. A girl with a known case of bipolar affective disorder on lithium therapy. Which statement is incorrect in respect to lithium? Come on, Maheshwari, join now. Can you please answer? A girl, a known case of bipolar affective disorder, which is incorrect with concern to lithium. Hemodialysis not useful for lithium overdose? No, it's a wrong statement. Wrong statement. We are using hemodialysis for treatment of lithium poisoning. Wrong. Lithium can decrease that. Yes, it may cause hypothyroidism. True statement. And lithium toxicity can be exacerbated by thiazide. Yes, true statement. Lithium is a phytotoxic if given to pregnant. Yes, true. So find out the incorrect mean. Answer is option number A. Option A. Good. Now, the question is, when you say lithium having narrow therapeutic index, so needs to be monitored. We do TDM. My question, when will you plan for hemodialysis in case of lithium overdose? What is the indication to do dialysis in lithium poisoning? For example, look here. Lithium having narrow index, you should know the range. Normally, as a maintenance therapy in bipolar disorder, lithium level should be around 0.5 to 0.8. It generally should be around 0.5 to 0.8. In mania, acute mania, we can increase dose, but better keep around 0.8 to 1.2. Be careful because when the level goes more than 1.5 milligram per liter, it causes toxicity. So lithium shows adverse effect when the level goes more than 1.5 milli equivalent per liter. Whereas if the level goes more than 4 milligram per liter, it needs hemodialysis. So in lithium poisoning, we do hemodialysis. Important. And then, what are the important adverse effects? I told more than 1.5 mean toxicity. What are the toxicity? For that, remember, when you say lithium adverse effect, what are the lithium adverse effect? For example, LI. Leukocyte counts are increased, called leukocytosis. T for tremor, fine tremors. H for hypothyroidism. This is option. They lower the thyroid level, hypothyroidism. Question, how they cause hypothyroidism? The reason for hypothyroidism, they inhibit release of T3, T4 from the follicle. Because of this reason, hypothyroidism. IU, increased urination, called polyuria. Here one question. Anybody? Lithium causing polyuria, we call this lithium induced diabetes insipidus. My question starts. Come on, everybody. Name the drug useful for treatment of lithium induced diabetes insipidus. That is amiloride. Amiloride, one of the epithelial sodium blocker. That's a drug of choice for treatment of lithium induced diabetes insipidus. Very good. Medrioids. Very good. M. Pregnant mother. In pregnant mother, for treating bipolar, if we give lithium, it causes teratogenicity. The baby born with the Epstein anomaly, that is cardiac problem, muscle weakness, flabby infant syndrome, and fetal hypothyroidism. And other two important adverse effects, lithium also causes some ECG changes, some T wave changes in ECG, also causes exacerbation of skin problem in psoriasis patient. Now, well, I finish lithium dialysis. I finish lithium toxicity. Other option is, so lithium since causing teratogenicity completely contraindicated for treating bipolar in pregnancy, even in lactation. And one more thing, it may cause some cardiac problem, so contraindicated in patient with sick sinus syndrome. Last finishing option, drug interaction. The preferred drug, this is also important, preferred drug for treatment of bipolar disorder in pregnancy, we can think of atypical antipsychotic like olanzapine, aripiprazole, like that. Okay, and then lithium drug interaction. Two type of drug interaction. One type is lithium aggravating the actions of skeletal muscle relaxants like succinylcholine and panacetin. Okay, lithium aggravating the actions of SMR. Because of aggravating SMR action, suppose a patient who is on having bipolar, who is on lithium therapy, when they go for some surgical procedure, during surgery, if we give these SMR, this may work a lot on causing more muscle weakness, causing risk of respiratory failure. To avoid that, if a patient on lithium, when they post for surgery, stop lithium 2 days before surgery, because lithium half-life is about 24 hours. But for safety wise, stop 2 days before surgery. This is also important. Last point. See, here I am telling lithium aggravating actions of SMR. But you should know there are some drugs aggravating lithium action. For example, diuretics and NSAIDs will aggravate lithium action, because diuretic and NSAID will inhibit excretion of lithium to the kidney. Because of inhibiting excretion, lithium level increases, causing toxicity. So, diuretic, thiazide, diuretic aggravate lithium toxicity. NSAID aggravate lithium toxicity. Okay. Next, a drug driver with a HIV positivity develops cryptococcal meningitis. Which drug best to start? Best to start. Look here. What answer? HIV patient, cryptococcal meningitis, what to start? Options are liposomal amphotericin B, fluconazole, liposomal amphotericin B with the 5-flucytosine, 5-flucytosine. What answer? The best is go for amphotericin B with the 5-flucytosine. So what they say, look here. For treating cryptococcal meningitis, induction starting therapy is combination of amphotericin B with 5-flucytosine. After stabilizing the patient, for maintenance therapy, you can go for initially fluconazole followed by oral fluconazole. So, in case of cryptococcal meningitis, best to start is combination of amphotericin B plus 5-flucytosine. After stabilizing the patient, as a maintenance therapy, put them on fluconazole IV followed by oral. Now, amphotericin B, antifungal drug. Fluconazole, azole antifungal. What is 5-flucytosine? Why do you want to combine here? Look at the concepts. Look here. 5-flucytosine, one of the anti-metabolites having antifungal activity. For example, imagine it's a fungus. So fungus. And imagine fungal cell membrane. If I give 5-flucytosine, this will enter into fungus. Within the fungus, my 5-flucytosine will be converted into 5-fluorouracil. 5-uracil. This in turn mechanism of action is going to inhibit thiamidylate synthetase enzyme, thereby inhibiting DNA synthesis. So 5-flucytosine, one of the anti-metabolite inhibiting fungal DNA synthesis. Okay, it is an anti-metabolite having anti-fungal action, and this is useful for treatment of cryptococcal meningitis as a combination with amphotericin B. Why? Why do you want to comment? Look here, amphotericin B, we know, acting on fungal cell membrane and forms spores, lot of pores. By forming micropore, all the fungal content leaks out. So amphotericin B making pores in the fungal cell membrane. Through the pore, my 5-flucytosine enter into fungus, attacking nucleus. So amphotericin B inhibiting cell membrane, 5-flucytosine attacking DNA. Because the two site of action, they have supra-additive synergism. So question, combination of amphotericin B plus 5-flucytosine having supra-additive synergistic action. That's why that's the best drug to start for treatment of cryptococcal meningitis. Next, oxytocin is useful for inducing the labor, should be avoided in pregnant female suffering from what? Pregnancy-induced hypertension, hyperthyroidism, heart failure or heart disease, abnormal position of the baby. Look here, oxytocin, actually speaking, a uterine contraction. Because of causing contraction is useful for induction of labor. That you know. Okay. Now it is avoided in which condition? The right answer for this question, if they given this option, it will be the answer. If the option not given, you can try this. First two are not a problem. Now I explain. Look here. Oxytocin, a post-pituitary hormone, we give oxytocin as an injection. When they give IV infusion, it acting on fundus of the uterus and body of the uterus, causing uterine contraction, thereby expelling the baby. So useful for induction. And is also causing contraction of myoepithelial cells of breast, causing milk ejection. That's also important action of oxytocin. Okay. Now, the oxytocin causing contraction, thereby useful for induction. After delivery of the baby, we continue the infusion to control postpartum hemorrhage. So the two most important indications are, number one, induction labor, number two, to control postpartum hemorrhage. But the problem is, since it's causing uterine contraction, the problems are if the patient having previous history of LSCS, if you give oxytocin, chances of uterine rupture is there. This you should keep. Okay. And oxytocin causing vasodilation, thereby risk of hypotension. And high dose oxytocin causes AIPG action, causing too much of water retention. See, because of causing hypotension, water retention, it's unsafe in heart failure patient. So avoid this in heart failure. And one more thing, since causing contraction, if the baby is in trans-like abnormal position, it may not going to have good labor, then fetus may go for distress. There is a second contraindication. The first contraindication, heart disease. Second only, abnormal fetal line. Okay. The best treatment for acromegaly. Can you please answer what you mentioned the answer, doctor? Best treatment for acromegaly. What you told? What do you mark it? Options are lanreotide depot, octreotide IV, terlipressin, somatostatin. What answer? See here, somatostatin, we know that hormone going to control growth hormone release, but it is short acting. It is short acting, and once you stop, there's a chances of reflex increase in growth hormone secretion, so it's not good. Terlipressin, a V1 agonist of vasopressin, that is useful as a vasoconstrictor, useful for treatment of esophageal varices. So ruled out. So options are either lanreotide depot or octreotide IV. See, acromegaly is the condition where we don't go for IV. Octreotide IV only for treatment of esophageal varices. Okay, normally it is given subcutaneous. So the answer for this question, option A, lanreotide depot preparation. That's the best answer. To explain further, look here. For treatment of acromegaly, we have something called somatostatin analogs. Somatostatin, a growth hormone inhibitory factor. So the analog we have. And also we have growth hormone receptor blockers we have. Now I will explain your option strictly because this under we teach in regular class. Now coming to your question, look at this. Somatostatin is a naturally occurring hormone. It's going to release from hypothalamus, going to act on pituitary. In the pituitary, controlling the release of growth hormone. But this is also going to control the release of thyroid sodium hormone, prolactin hormone. So it's a non-specific, going to control all hormones like prolactin, TSH, everything. And somatostatin also released from delta cells of pancreas. It's going to inhibit insulin and glucagon secretion. So when I use somatostatin, it unnecessarily inhibits insulin secretion causing diabetes. So the disadvantage. What are the disadvantage of somatostatin? Half-life is short, lack of specificity, and rebound rise of growth hormone level after stopping somatostatin. So we don't go for somatostatin. We go for somatostatin analog. What are they? The analogs are, we have octreotide, lanreotide, vepriotide, secretide. All are commonly given as a subcutaneous injection. So in your answer, lanreotide subcutaneous depot is the right answer. Octreotide IV only for is varices, not for this one. For octreotide, for this case only subcutaneous. So answer lanreotide. In this junction, you please note, not only somatostatin analog. There's one more group of drug going to inhibit growth hormone release. They call D2 analog, like bromocriptine, cabergoline. They also able to decreases growth hormone release, thereby can be useful for acromegaly. In fact, advantage, these are the only one group of drug useful for acromegaly orally. So the orally useful drug for treatment of acromegaly mean D2 analog like bromocriptine and cabergoline. Here one extra point. See, we have one somatostatin analog named by peseriodide. Peseriodide is somatostatin analog. This is the one useful for treatment of acromegaly. as well as useful for treatment of Cushing's syndrome. This is important. Name the somatostatin analog useful for treatment of acromegaly and also for Cushing's syndrome. In answer, pasireotide, because it is able to reduce steroid, corticosteroid synthesis also, thereby useful for Cushing's syndrome also. And finally, look at this. Octreotide normally given only subcutaneous, never oral. IV only for emergency. Okay. C normally given subcutaneously for acromegaly and for treatment of Costner diarrhea, HIV diarrhea, and in case of varices given IV. That's about octreotide. Of course, octreotide can also useful for treatment of insulinoma and glucagonoma because they are able to control insulin and glucagon secretion. And the adverse effects, you should know, it causes gallstone formation, B12 deficiency, megaloblastic anemia. And because of inhibiting insulin release, risk of diabetes. Okay. And this is another very important. Can you please answer Dr. Madriarch or Mageshwari or Wasim, whoever is there? Please answer. Name one growth hormone receptor blocker useful. Growth hormone receptor blocker useful for treatment of acromegaly. I want drug name, doctor. Name one growth hormone receptor blocker. For example, pegozamin. Pegozamin, a growth hormone receptor blocker useful for treatment of acromegaly. Okay. It's also given subcutaneously. So in summary, for the treatment of acromegaly, we have something called octreotide, lanreotide given subcutaneously. They call somatostatin analog. And then we have pegozamin growth hormone receptor blocker. And then we have D2 analog like bromocriptine, cavacodine, or oral drug. The summary. Next, a patient comes with the breathlessness, dry mouth, with reduced exercise capacity. On examination, diagnosis of pulmonary fibrosis is made. Which of following drug can be useful for treatment of this condition? Answers are roflumilast, perfenidone, doxaprom, imatinib. What answer? The answer is perfenidone. Actually, it's a drug targeting against some growth factors and also targeting against procollagenase 1 and 2. Because of targeting against these factors prevents lung fibrosis. It is approved for treatment of idiopathic pulmonary fibrosis. So, newer drug, this may be difficult for you. Okay. And other options are easy. By rule outing other option, you can reach a diagnosis. For example, roflumilast, a selective PDE4 blocker used as a bronchodilator, useful for treatment of COPD. Doxaprom is a respiratory center stimulant, useful for treatment of respiratory failure. Imatinib, tyrosine kinase inhibitor, in fact, a drug of choice for CML, chronic myeloid leukemia. So by rule outing the option, we can reach diagnosis. Okay. And finally, so related to this, I'll do one more point. We have one new drug called erdafitinib. It is one of the small molecule like tyrosine kinase, one of the small molecule blocker targeting against fibroblast growth factor receptor kinase. Because of targeting against fibroblast factor prevents fibrosis, useful to prevent fibrosis. It is also useful for treatment of lung fibrosis. In fact, it is useful for treatment of urothelial cancer also, but having anti-fibroblast activity. Okay. Similarly, we have one drug called mitomycin C. Mitomycin. This also having anti-fibroblast action, thereby useful for prevention of laryngeotracheal stenosis. So metamycin, one of the antibiotic anti-cancer drug useful to control psoriasis. Next, a 60-year-old male cancer patient on chemotherapy developed neutropenia. Which of following drug useful to increases the immunity in this patient? The main following cancer chemotherapy developed myelosuppression in the form of neutropenia. So question, what are the drugs useful for treatment of neutropenia? When neutropenia deficiency is causing immunity problem, B cells when go for deficiency, immunity problem going for infection. So here we need some neutropenic supports. What are drugs useful for treating this? Options are filgrastim, darbepoetin, opalvecin, iron dextran. See, very simple. Iron dextran, iron mean useful for treatment of anemia. So ruled out. Darbepoetin, poetin like erythropoietin, epoetin. It's also for anemia. Ruled out. So only two options are there. Filgrastim, opalvecin. Opalvecin is a interleukin 11 analog useful for treatment of anti-cancer drug-induced thrombocytopenia. Ruled out. So only one option called filgrastim. That's answer. Filgrastim is a colony stimulating factor useful for treatment of neutropenia. That means that for answering this question, when we teach in our regular class, we discuss how to manage anti-cancer drug-induced problem. For example, one of the problem is myelosuppression. In myelosuppression, three components are there. Something called neutropenia, something called anemia, something called thrombocytopenia. That means my question, if a patient following chemotherapy developed neutropenia, means for correcting this condition, we have one group of drug called colony stimulating factors. In this two class of drug, one is called recombinant granulocyte colony stimulating factor. For example, filgrastim, pegfilgrastim, linograstim. They give an option, this one in your exam. So remember, filgrastim is a recombinant granulocyte colony stimulating factor useful for treatment of neutropenia. Similarly, we have one more group of drug called granulocyte monocyte colony stimulating factors. For example, sargramostim, molgramstim, sargramostim, molgramstim. They are called granulocyte monocyte colony stimulating factors. They are also useful for neutropenia. So all these are called colony stimulating factor. Whereas if there is anemia following chemo, if there is anemia, for treating anemia, we have something called erythropoietin preparation like darbepoetin or epoetin. So darbepoetin, epoetin useful for treatment of anemia. And finally, for treatment of anti-cancer drug-induced thrombocytopenia, we have one thing called opalvecin. Very important. Opalvecin, a interleukin 11 analog useful for treatment of anti-cancer drug-induced thrombocytopenia. Of course, we also try thrombopoietin, but most commonly used is opalvecin, so interleukin 11 analog. Next, a 5-year-old girl who was being prescribed iron supplement in the form of syrup has consumed it high dose and now having abdomen pain, vomiting. Which antidote can be useful for treating this patient? Come on, all of you. I am reaching the last question. Can I please answer? The answer is, here the patient is acute iron overdose causing abdominal symptom like pain, vomiting, all these things. So question, options are, we have desferriaxamine, iron dextran, dimercaprol, succinylcholine. Very good. The answer is option A, desferriaxamine. So here is the case of acute iron poisoning. For treatment of this iron poisoning, we use some iron chelate. So the best answer, desferriaxamine. I go for all the points. Look here. For example, look here. In case of heavy metal poisoning, for treating this poisoning, we have something called chelating agent. For example, For treatment of iron poisoning, the best drugs are we having desferrioxamine, deferriprone, one more drug, desraxazine, all are iron chelator. Here they give an option desferrioxamine in your question. So this is the right choice. And here desferrioxamine in injectable, deferriprone oral drug. So injectable iron chelator desferrioxamine, oral iron chelator deferriprone. Extra point dexraxazine. It's also iron chelator, useful for treating iron poisoning. Extra 1 point. It is also useful for treatment of anti-cancer drug-induced cardiotoxicity. For example, doxorubicin, one of the antibiotic anti-cancer drug causing adverse effect of cardiomyopathy and congestive cardiac failure. To prevent the cardiotoxicity of doxorubicin, we are using this as an antidote because doxorubicin, in the presence of iron molecule, they form some free radical. The free radical causes cardiotoxicity. So to avoid this, we need iron chelator. For that, best is dexraxazine. So 2 point. For see, if a patient having acute iron poisoning, usually this occur in patients who are going for repeated blood transfusion. For them, best is go for desferrioxamine or deferriprone. Whereas antibiotic anti-cancer drug like doxorubicin causing cardiomyopathy, to control the toxicity of doxorubicin, we also give dexraxazine as an iron chelator. And to overcome the other options, look here. We have one thing called BAL, also called dimercaprol. It's a British anti-levisite. It is the broad spectrum chelating agent. That means BAL useful for arsenic poisoning, lead poisoning, mercury poisoning, like this. So BAL is for all poisoning. Even succinylcholine also useful for lead poisoning. But one question to all people, my last question, can you please answer? British anti-levisite useful for so many metal poisoning, but you have to tell me BAL is contraindicated for treatment of which heavy metal poisoning? Remember, BAL therapy contraindicated for treatment of iron poisoning and cadmium. For treatment of iron poisoning and cadmium poisoning, we should not use. Yes, good. Ferrous, very good. For iron poisoning and cadmium. For iron poisoning and cadmium, we should not use, because in this poisoning, if we give BAL, it forms a toxic compound causing more problem. Okay, that's about chelating agent based question. That means, doctor, I have aligned all the question whatever asked in FMGE examination in that order. GP question, ANS question, CNS question, cardiology question, renal, blood, and antibiotic chapter question, anti-cancer question, like that order. I think all the questions are discussed. Okay, and just 1 point out here. For copper poisoning, we can use some antidote like D-penicillamine, trientine, zinc sulfate, quadrasulfate. Okay. In this, the D-penicillamine causes some adverse effect like SLE, optic So today, for copper poisoning, the best drug will be zinc sulfate. That is the best. Okay. So it's a whole revision, and also I covered all the points. I think all are answering nicely. So everybody going to clear FMGE, no doubt. So once the result comes, just give your number, your feedback, all these things. Okay. So thank you. Have a bright future. May God bless you. All the very best. I think all the questions I covered so far. Okay. Thank you. Thank you very much, Dr. Medriot. Definitely going to get a good rank, no doubts. All the very best.